Hey, good morning, guys. Welcome to Grand Rounds for Mentoring Functional Medicine. I'm Dr. Patrick Garrett. I'll be your host today. And got a few presentations today, but I'll go first. And last week we talked about gout. And then this week we're going to talk about something that's pretty common. It used to not exist, and then it started existing, and then it got a new name, and now it's going to be more and more common. So this case is a 41-year-old, this case 41-year-old female with non-alcoholic fatty liver disease. Now, you'll probably see this with both men and women. So your liver's pretty amazing. You know, it's you can chop out 60% of your liver and go catfishing or crawdadding, and it'll all grow back. So anything that destroys the liver, like Tylenol, it is pretty significant. So traditionally with liver stuff, it's always like alcoholism, hepatitis. That's pretty much all we learned in graduate school, right? And then started getting these patients, and it was quite a few that they didn't have hepatitis. Everything was negative, and then they weren't alcoholics, so it wasn't cirrhosis. And I was like, we didn't learn about this. And then I took this course through the Harvard Lifestyle Medicine program on NAFLD, or non-alcoholic fatty liver disease, and I took one on non-alcoholic steatohepatitis, which is cirrhosis from fatty liver. And I was like, oh my gosh, this explains so much of what's going on now. And so your liver packages sugar up, all the excess sugar that you eat, the 170 pounds of added sugar every year for Americans. It packages up into very low density lipoproteins, VLDLs, which if you multiply that times 5, you get triglycerides. So that's where they come up with those numbers for the cholesterol test. But those VLDLs are trying to package these up and distribute them to be fat over your muscles for later energy. And then whatever's left is packaging up over your liver. And so then eventually you're going to get fatty liver. So that's the non-alcoholic fatty liver disease. Now the new term for that is metabolic non-alcoholic fatty liver disease. But it would used to take like an alcoholic 35 years of hardcore alcoholism just to damage the liver like that, right? You can do it in 5 to 10 years now with just your diet. The body was, again, it's not a disease, it's an absolute normal outcome. There was no time in history that the body was designed to deal with 170 pounds of added sugar every single year in 50 different forms. So we have figured out the breaking point for the liver, and we got a new disease for it that we've incorporated an even better metabolic name for it. So the other part is NASH. I mean, basically when it's fatty enough that starts scarring up and damaging, well, then that becomes cirrhosis of the liver, but instead of alcohol and hepatitis damaging the liver, now it's just food. So that's NASH, or they call it MASH, or MNASH, so metabolic non-alcoholic steatohepatitis. So that's great. So that's why we have this sudden epidemic of this new liver disease that's not caused by alcohol or drugs and hepatitis. So you're going to see this quite a bit, and it should be really easy to fix. Think of it like diabetes for the liver, obesity for the liver. So how do you fix obesity? Sustainable weight loss is always stop causing it and burn off the stored and then maintain healthy. So your liver's no different. We gotta burn that off. The problem is with your liver is most of your fat is stored over muscles for energy. So it's directly over the muscles it wants to feed. The liver is not doing any activity. It's not doing aerobic glycolysis, any of that kind of stuff. So it's a little bit harder to convert that and burn it off, but it's totally doable, and it really doesn't take too long. So in this case, 41-year-old female, we're going to see this equal with men and women. 4 years of non-alcoholic fatty liver disease, and it was discovered after persistent elevated liver enzymes, and then finally did some imaging and demonstrated a little bit of hepatic steatosis, so fat, condition of fat on the liver. Now, the liver enzymes that we're typically looking at is ALT, AST, and maybe ALP or alkaline phosphatase. But do you guys know the one true actual liver enzyme? So if you're going to monitor medication or monitor non-alcoholic fatty liver disease, you always use GGT. GGT is only liver. AST, ALT are elevated for inflammation, infections, and other stuff. So it's not a true liver indicator. So the first thing with someone that gets diagnosed without the imaging, you always want to do a follow-up GGT. Is it actually the liver that's inflamed that's bringing those numbers consistently or persistently elevated or up or elevated? Now, if they do a sono or MRI and they see the images on there, yeah, that's a whole different thing. Now, quality of life, really, if you slow down the liver, you kind of congest the liver. So that's our major detoxification pathway. Half medications are processed through the liver, the other half through the kidneys. But all the toxins that you're getting exposed to all day, every day, are mostly processed through the liver. So liver congestion through fat is going to slow down that. That will then typically make you feel more toxic, more fatigue with that. So chronic fatigue, often reduced exercise tolerance, progressive weight gain, obviously, because that's why they have fatty liver. Frustration with unsuccessful dieting. That's why we do sustainable lifestyle changes we do sustainable weight loss, which is one of the featured topics in our course. And that's totally different from what everybody else is doing. And then worried about, of course, fibrosis and cirrhosis and losing her liver, because then you're pretty screwed. Now, fatty liver by itself often is asymptomatic, just so you know. It's usually an incidental finding that we see on labs. And it's normal, just so you know, to have like elevated AST, ALT, because again, the inflammation and other stuff. But even your liver itself, you know, it's supposed to swell and heal and swell and heal. So even numbers going up aren't really bad, because it's supposed to be dealing with stuff, and then it cleans it up and then it shrinks back to normal. Now, the numbers we like to see in functional medicine or functional lifestyle medicine is usually below 20. So an AST, ALT below 20, inflammation, liver, you're doing pretty good, right? And then labs started pushing that up to about 30, they did 29. Now they do 30, 35, 40, and I just saw a lab the other day where both AST and ALT were 50 as normal. So it's kind of odd, because usually we tighten up the numbers to get people on drugs earlier, but there's not really good drugs for this. So I guess they're just expanding it. And a lot of times, if you guys don't know, like there's no one lab range for any lab, hospital, clinic. You can get three different, same lab done in three different places, have three different ranges. So you may be 50 normal at the hospital, but 50 is high at the clinic. So just know that's true. And then, so you got to have your own kind of like ideal ranges for the most part. But when it gets to 10 times that number, so when you start looking at 200, that's when we're really, really concerned, okay? So 200 to 500, where it's 10 times that number for AST, ALT, that's where you're gonna get my attention. The 160s and 70s, like great, that's gonna be fast and easy to fix, okay? So I don't get too excited about those. And then again, we always wanna see pattern. So it went up, but did it keep going up? Did it stay the same? Did it go down? So with one number, back when I used to teach the other postdoctoral program, it was like, okay, patient has a blood sugar of 300, what should we do? And then everybody gets excited, like, oh my God, this person's gonna die, we gotta get super aggressive. But what if last month it was 450? Oh, well, they're doing good. They just need to keep up what they're doing. So without extra numbers, we don't know the pattern of this. So if you see a AST that's, say, 60, is it 60 getting better or 60 getting worse? We don't know. We always assume the worst, right? Because that gives us intervention, and like we can do something about this. But sometimes we want to kind of like pull research back from 6 months ago or a year ago and kind of see if we see something to be alarmed about, first of all. All right. So quality of life may or may not be an issue, especially in the beginning, but eventually fatigue really is going to be a big one with that. Now, because it's fat, they did metformin and atorvastatin, but statins and PPIs are one of the highest warning rates in pharmacopoeia for long-term use. You can't take those for very long. And when we talk about cholesterol myth, we talk about cholesterol paradox, we talk about the detriments or the side effects of the process of blocking cholesterol. Like, that's a huge issue. That is dramatic quality of life. And again, people that lower cholesterol have higher mortality than those that have higher cholesterol. So that's its own discussion we'll talk about. But with metformin, it also depletes B12. And so B12 is your brain function, memory, mood, alertness, detoxification through the liver. So the metformin is actually decreasing the vitamin that helps convert S-acetylhomocysteine, and then through B6 converts into glutathione to detoxify the liver. So the detoxification process is hindered by the medication that you're trying to manage it with. That's not a good thing. And then B12, we'll harp on this quite a bit because it's our psychometabolic pathways. But you have a homocysteine pathway that feeds in the folate pathway that feeds in the bioterapin pathway. But B12 helps convert through the folate pathway, the methyltetrahydrofolate reductase pathway. And then that then feeds into the bioterapin, so BH2 becomes BH4, and then bioterapin is what converts amino acids into hormones and neurotransmitters. So if we shut down or slow down with medication B12, we slow all these processes down. So now you shouldn't be making serotonin very well, melatonin very well, dopamine, epinephrine, norepinephrine, PEA, and octopamine for behavior, and tyramine, so thyroid hormone. So it's just slow down all that conversion, which then is your whole entire quality of life, and everything gets worse with that. So, and then of course metformin doesn't reverse obesity or 170 pounds of added sugar to your diet. So then we have the statins, and again, that's just a whole mess. Like, that's not going to do anything for this. That's ridiculous. So lowering cholesterol is, again, going to make the lab look better, but it's not going to make your condition better. And then our whole goal with this is really just preventing non-alcoholic fatty liver disease from becoming non-alcoholic steatohepatitis or cirrhosis, long-term damage. So this is a really, really serious case, even though it's a very simple case and a very common thing that you see, but this could end them. You can't live without a liver. So typical medical treatment, basically weight reduction. And now if they have a little bit of NASH, we won't talk about this much, but if they do have a little NASH, that's scar tissue is fibrin. Fibrin is eaten through proteolytic enzyme therapy. So like a repair gold that has like ratio peptidase, it will go through, if you take that at night, double dose before bed, otherwise it'll just digest food. Then you have 8 hours of uninterrupted fibrin digestion. So it's busting clots and scar tissue and clean up the liver and joints and all that stuff. So I do like proteolytic therapy for this. We usually don't do it because we don't really see NASHs, because again, this is kind of a slow ongoing epidemic now. So we typically do the functional lifestyle medicine protocol, which again, do the intake, tell me everything you're eating, drinking, breathing, rubbing, and peeing and pooping, everything from head to toe that's falling apart. So we have a whole clinical picture, not just the liver inflammation, because that's not even going to be the major consideration here. Then we do food sensitivities because we're dealing with inflammatory stuff, and then they usually have a bunch of other stuff we want to get rid of faster, so we always do the food sensitivity. And then we go through the lifestyle medicine approach, so we again dramatically change food. So we want to get rid of the inflammatory foods. We want to eat anti-inflammatory, so we reverse this faster. Dramatically knock down glucose intake. But this is another place too where the stress management, the neuroplasticity, resiliency is so critical here. Not just because it suppresses immune system, but your liver makes sugar in response to stress, further complicating a too much sugar problem here, right? So gluconeogenesis is how your liver reacts to stress. So you literally jack up more sugar in an organ that's being damaged because of too much sugar. So that quality of life, stoicism, the stuff that we teach is critical for this. And then kind of monitoring their labs and making sure, again, that we're seeing the numbers go down, and they tend to go down pretty quickly. So again, this isn't going to be a long drawn out thing for you. We've had some really kind of high numbers for liver. I think our last one last week, their actual hematochromatosis is normal for the first time ever. So we got that back to normal. And so his ferritin was 3,000. Now is that 160? I think it's 160 now. It's the highest of the ferritin, but it's normal now. And so he didn't have to bloodlet now to chronically manage his hemochromatosis. So all those changes we made, basically it's addressing what's causing that and fixing that. But his fatty liver disease is back to normal now. So his liver enzymes, I believe they were below 30. So again, not ideal, not perfect yet, but he doesn't have to worry about this constant in the back of his head, I'm gonna lose my liver because his numbers were so high. And then I'm sorry, on this one, I did not put the numbers down that we started with. But 5 months was our outcome, last follow-up. And substantial improvement, of course, energy, body composition, because again, you're just naturally going to lose weight, getting stronger because we're talking about purposeful movement, purposeful lifestyle. And liver enzymes were within the 20-30 range for AST, ALT, but we also did a GGT, which was normal. So then we were like, okay, it definitely is great. Triglycerides, which again is our concern with fatty liver because that's sugar converting to VLDLs, or they're packaged up in little chylomicrons, and then they're supposed to be transported out as triglycerides to make fat in your gut and arms and back, and so you can be a big back, big belly or something with all that potential energy. So of course the triglycerides go down, and a lot of times those will be for fatty liver up around 300 to 1500. Like they'll be crazy high. What that means is they're consuming so much more sugar and stressing so much sugar from the liver, they can't even package it up and convert it to fat fast enough. So that backflow is the triglycerides, or the VLDLs times 5. And he had a big concern because he was a metabolic dysfunction phenotype. So he was told it was genetic, and that's why he has fatty liver disease, not his horrible diet and not moving. So otherwise, that's one that we see a lot, and it's a very easy fix for you. So again, not anything out of the ordinary or exceptional. It's just, again, creating a lifestyle that's consistent with life longevity without gimmicks and bullshit. So if you can do that, you can fix almost all these things. Very, very straightforward. All right, so next week we're gonna have case number 5, and that's a 20-year-old male with reflux. And reflux, much like Crohn's, super easy to reverse. And you want to do that before they get their Barrett's esophagus or esophagitis issues and dysplastic changes. So this is a good one. It's very common. I think about 40% of Americans have reflux. So this can be life-changing because of the medication that they use to treat it. That then causes all the other problems. All right, guys. Look forward to seeing you next week. Hope you help fix some people here. All right. Bye, you guys.